I think we're just going to start that in terms of any financial interest or so. So this is just a list of funding agencies that have been funding different types of work, and really no conflict and no financial conflict related to this presentation or other presentations, I should say. And so nothing to mitigate in terms of potential bias, but this would be my statement. So I think what I hope we can achieve today is 4 objectives. One is describing, succinctly, is the epidemiology and the phenomenology of late life schizophrenia and late life psychosis, and this distinguish it maybe from other conditions. And in geriatric psychiatry, we care a lot of the cognition. So also describing the cognitive profile of individual with schizophrenia across the lifespan, especially in late life. And maybe also from a clinical perspective, identify potential factors that we could modify maybe to potentially improve or reduce the cognitive deficits in schizophrenia. And then at the end, we maybe describe a bit the interventions that could enhance function in older individuals with schizophrenia. I'm presenting from CAMH. There are a lot of codes, hopefully not a lot. So I'm not gonna pause every time there's a code. I'll try to speak louder, but I'm sorry for any disruption. I can't do much about it. Otherwise, we'll be pausing a lot. So just to talk about some numbers and statistics. So around in 2004, and we may, these numbers kind of still, I think, would be projected to this day, that more than 10% of people with schizophrenia were age 50 or older in 2004 in Canada specifically. And in general, based on different settings, whether in the US or in Canada or other countries, most individuals live in the community. 85% of older people with schizophrenia live in the community. Around 15 to 20% people with schizophrenia live in institutionalized settings like long-term care home or hospitals. Although what's interesting that most of our knowledge about late life schizophrenia is from institutionalized settings, unfortunately, because I think it's typically much easier to study the population who live in institutional settings than in the community. There are 10 long-term studies, kind of cohort studies that looked at the trajectories of schizophrenia late in life, and with a follow-up that ranges from 20 to 35 years. And in general, there is significant clinical improvement. And here by this, we mean typically the symptoms, the classical symptoms of schizophrenia, the positive symptoms or the negative symptoms, but more so, I would say, positive symptoms, that there is on median, 53% of people significantly improve from a social recovery, from a functional recovery. Also around 50% of people are quote unquote recover. Now, by recovery, there are different studies have different definitions, and we don't have the time to go over that, but there is significant improvement, we should say, that for large proportion of individuals with schizophrenia. And like I mentioned, about 20% remain institutionalized. I like to use this slide just to demonstrate, and this has been replicated in another setting as well, that the financial burden of an illness like schizophrenia is high compared to other conditions. So here, if you look at, this is from the US, looking at schizophrenia versus non-schizophrenia for 2 different cohorts. And what you can see is that the cost of the illness is high around the first episode, around the first onset of the illness. Then it goes relatively down, but then it increases again late in life. And that's probably because of transitions, because of the loss of supports. And however, most of our investment, especially on the research, happens early in life. And we have a lot of studies in first episode versus late life schizophrenia. When we talk about older individuals with schizophrenia, I think we need to think about individuals who've had their illness from early on in life, and then they grew old with schizophrenia. But there is also up to around 25% of patients with schizophrenia have their onset late in life. So the first time they meet the criteria for schizophrenia late in life, and we call those individuals with late onset schizophrenia. So that's between the age of 40 and 60. There's also another condition called very late onset schizophrenia like psychosis. So these are individuals who don't have necessarily neurodegenerative disease like dementia, but they have their first episode of psychosis above the age of 60, and they represent 3% of all patients with schizophrenia. But by far, the majority of people would have had their illness early on, and they just grow older with this chronic illness. Some differentiating features that could differentiate people with early onset versus late onset. You see proportionally more women who experience late onset schizophrenia than compared to early onset. Patients with late onset schizophrenia tend to have more positive symptoms than negative symptoms, again, compared to those with early onset schizophrenia. There is more variability in the cognitive profile and the type of cognitive deficits that patients experience. So in general, those who have early onset schizophrenia, they have impairment across different domains of cognition, across whether it's attention, memory, working memory, executive function, or others. And they tend to be moderate to severe. But you see more variation. So you have certain domains maybe more preserved in people with late onset schizophrenia. And one last point that's relevant for the management is that people with late onset schizophrenia, they tend to respond to lower doses of antipsychotic compared to those with earlier onset. This is a table kind of to try to help us differentiate the type of psychosis and type of clinical features that distinguish older people with schizophrenia from those who have psychosis related to Alzheimer's dementia in this case. So what you see is that the type of delusions, if we think about thought control, you see much more prevalent in patients with schizophrenia compared to people with Alzheimer's disease, versus the idea of someone stealing from me. So these kind of type of delusions, you may see them kind of maybe equally in both conditions. The type of hallucinations, you see more prevalence of visual hallucination in people with neurodegenerative disease like Alzheimer's disease than compared to schizophrenia. Auditory may be a bit more prevalent in people with schizophrenia. You can look at also family history, and if there is family history of dementia versus family history of major mental illness. The course here, as we know, the typical dementia is a progressive decline. Although, as we mentioned before, there may be some variation in terms of the functional course of the illness in people with schizophrenia, where some people may experience improvement or even recovery late in life, people with schizophrenia. Also, in terms of distinguishing the two conditions, people who are all with schizophrenia, they tend to be socially single, socially isolated, versus those who experience dementia. You see more people who've been married, who have partners, who are who've been able to form relationships throughout their lives versus people with schizophrenia. I use this slide usually to kind of describe the different factors that contribute to the daily function of individuals with schizophrenia, including late in life. And one of the main determinants is their cognitive profile, which kind of determines the day-to-day function through what we call the functional capacities. So and the reason why we talk about functional capacity, because unfortunately, a lot of the day-to-day function of individuals with schizophrenia, including older people, is also determined by social factors. So if I ask my patient, an older patient, whether she is contacting her family on a regular basis, is she maintaining contact with her family? One factor could be because she does not have access to a phone to actually, so that's a social factor. It's not necessarily because she doesn't have the functional capacity to be able to organize herself and make a phone call to family members. So that's why a lot of the studies that we look at how cognition determines function, we use measure of functional capacity rather than and try to distinguish what is or separate what is caused by the environment versus the actual cognitive impairment. So in terms of the functional trajectory of older people with schizophrenia, we see relatives. This is from the studies that look at the institutionalized patients, and we see a relative stability in terms of risk of decline or developing dementia using that clinical dementia rating scale. And then you see that acceleration in daily function around the age of 60. So there's a significant increase in risk of cognitive decline among those who are institutionalized. However, we don't see that profile. We don't see that typically that trajectory in people who are living mostly in the community, where typically what we see is ongoing cognitive decline, impairment compared to healthy individuals. So here we're comparing normal cognition versus people with schizophrenia. But there is no acceleration of cognitive impairment over the follow-up. Although the follow-up in the community setting the studies tend to be looking at shorter follow-up compared to institutionalized studies. We also, this is more from cross-sectional studies looking at the lifespan. So here what we're looking at is comparing healthy individuals represented by the white bars across different cognitive domains. So here we're looking at visual memory. This is information processing speed, digital coding, mazes, which look at executive function. So what you're looking at is white bars are healthy individuals, black bars are individuals with schizophrenia across different age groups. So less than 40, 40 to 49, 50 to 59, and more than 60 or 60 and above. So what you can see is that there's always a gap in cognitive function, but there is no acceleration of this gap. There's no significant widening of the gap. And this is across different domains as well. So here we're looking at verbal memory, fluency, or social function. However, when we look at epidemiological studies, so this is looking at up to 6 years of follow-up. Still, individuals with schizophrenia are at, this is from the community, they do experience a higher risk of developing dementia and this risk starts to increase around the age of 60. So this is more consistent with the institutionalized studies. This is from the epidemiological studies. Again, when we look at very long longitudinal trajectories compared to those individuals without schizophrenia. So overall, I think individuals with schizophrenia are at a higher risk of developing dementia. However, it's not clear whether what are the factors that could be contributing to this higher risk, and what cognitive domain could be capturing this higher risk if we look at just cognition in shorter follow-up in the community. So what about those factors that that could increase the risk of cognitive decline, maybe a dementia-like picture that we could modify? There are many factors, but I chose to focus on a couple where we've done some work, our team, but also that we as clinicians, we can maybe intervene, clinically at this time. So one is the anticholinergic burden. We know from non-schizophrenia studies from communities that high anticholinergic burden does impair cognition among older community-dwelling adults. We know that's been associated with increased brain atrophy. And we know also that cumulative exposure to anticholinergic drug increase risk of dementia. In schizophrenia specifically, there have been studies showing in younger individuals that anticholinergic burden has been associated with impairment in verbal memory, but also has been associated with impairing the ability to benefit from cognitive training programs. So not just kind of impairing their memory, but also impairing their ability to benefit from interventions, as well as impairing the ability to benefit from psychosocial interventions through its effect on cognition. We also published a study where we looked at the profile of older people with schizophrenia, the cognitive profile of older people with schizophrenia, and whether high anticholinergic burden was associated with deficits that may be more linked to schizophrenia versus deficit that are more typical of patients with Alzheimer's dementia. And we saw that distinction that high anticholinergic burden was associated with the cognitive profile that is more consistent with Alzheimer's dementia than those impairments that we see more in schizophrenia, like executive function. We also more recently published a paper that we showed that high anticholinergic burden, especially in older people with schizophrenia, is associated with direct impact on the functional capacity that I just mentioned to you earlier. So the ability to make a phone call, the capacity to navigate a map, the capacity to follow a recipe to make a a certain meal. So we test individuals in a lab setting whether they are able to perform those tasks. And we showed that high anticholinergic burden has a direct impact on those abilities, independent of its impact on cognition itself, which again raises this idea that question of there is some impairment in function that maybe we're not capturing when we study only cognition in older people with schizophrenia. So another focus that I want to talk about is a focus on blocking the D2 receptors and dopaminergic receptor. And the reason why, because we know a lot of all antipsychotics, to work as an antipsychotic, you have to block the dopaminergic receptor. So initially, there was a lot of, when the second generation antipsychotic, as some of you may know, that they've been thought that they would improve cognition. However, we learned from the Katie study that they don't improve cognition compared to first generation antipsychotics. But also, we've learned over the years that high dopaminergic blockade could be associated with actually cognitive impairment in individuals with schizophrenia. This is in adults. So one study we conducted a few years ago, where we enrolled individuals who have schizophrenia, who are at the age 50 or above and have been stable on either risperidone or olanzapine for at least 6 months. And then we aimed to reduce the dose of the antipsychotic by up to 40%, as long as they continue to be clinically stable. And then we did PET scans before and after the dose reduction to try to detect whether the threshold of dopaminergic blockade is going to be lower in older individuals compared to younger individuals with schizophrenia to maintain stability. So what was interesting from the study is that no one really relapsed after reducing the dose by up to 40%. So that's, in some sense, we failed to detect that threshold, because really no one relapsed by an a priori definition of relapse. Only 4 individuals experienced clinical deterioration, which didn't meet the cutoff of relapse, and that their symptoms went back resolved after adjusting the dose. And then they did experience significant improvement in side effects, especially the motor side effects, and lower blockade of the dopaminergic receptor by PET scans. With respect to cognition, what we found is that the increased availability of the receptors, dopaminergic receptor in the brain, was associated with improvement on cognition. This is using the R bands, which is measuring here global cognition. And what was more interesting to me is that at baseline, so before we reduced the dose of the antipsychotic, there was no significant association between how much the dopaminergic receptors were blocked and cognition. However, after we freed some of these receptors from blocking them with antipsychotic, then we were able to see this association between dopaminergic the occupancy of the dopaminergic receptor and cognition, kind of suggesting to me is that after we relieved that blockade, that the dopaminergic receptors at least started to contribute more to cognitive function, which we were depriving that contribution maybe before reducing the dose. I'll few more slides and I'll be ending. I think other than talking about the antipsychotics, there are, in terms of how do we care for older people with schizophrenia, in addition to medication management, I think it's important to think about it, think about care from a chronic care model, thinking about coordination of services for those individuals, thinking about social reintegration, because many of those have been isolated because of the illness throughout their lives, and they're losing the supports, they're losing the family members who used to support them throughout the adulthood years. Antipsychotic, this is, you know, the best evidence, the best studies, medication, not that the more controlled studies are for olanzapine or risperidone. That doesn't suggest necessarily that they are better than other antipsychotics, just that they haven't been studied as much in older individuals. So we tend to recommend, and we have a pathway at CAMH, we tend to recommend risperidone first because it's less anticholinergic than olanzapine. We do use clozapine for older people with schizophrenia for when there's treatment resistance, even though it's highly anticholinergic, but at least it's been shown to be, as we know, superior to other antipsychotic for treatment-resistant psychosis. This is a table we usually recommend in terms of the dosing, the initial dosing for different antipsychotics, titration steps, and the maintenance. There are some interventions that target directly function, so not necessarily functional capacity and day-to-day function, by bypassing to an extent cognition to try to improve function of older people with schizophrenia. I'll just mention the names, and you see the references. There have been some with some benefit, on not modest benefit, I would say, moderate. We need to improve on these interventions. One is called the functional adaptation skills training that targets medication management, social skills, communication skills, and so on. Another intervention that's been shown is called the HOPES intervention, so that combines psychosocial intervention with preventative healthcare, that was led in this study by nursing staff. And the last one is something called cognitive behavioral social skills training. Again, it's a groups type of setting that focuses on both addressing memory-related deficits that are observed in older people with schizophrenia, as well as the other items, medication management, social integration, and so on. So that's it. 3:25. Thank you for listening, and I think we have a lot of time for questions, I hope.